All right, Committee on Health and Human Services Finance will come to order. Representative Albright moves approval of the minutes for March 29th. Any additions or corrections or changes? Seeing none, all those in favor of approval of the minutes from March 29th, please say aye. Those opposed, no. Minutes are adopted. Members, today we will have informational hearings on two bills. We won't be taking action on either bill. The first bill up is House File 747, Representative Hamilton. Representative Hamilton, I understand we have testifiers, so let's get to your bill immediately. Representative Hamilton, to your bill.
Well, thank you, Mr. Chairman and members of the committee. And I'm going to, I've been thinking about how I wanted to approach this. And I'm going to do my best, at least initially, to stick to the script. And I don't always do that well.
There's always a first.
Right? And so I want to thank you first, Mr. Chairman, for providing me with a hearing. You're a good man of your word, and I appreciate that. I'd also like to say thank you to staff. I understand this is the final week, and everybody's working long hours and overtime, and thank you for your all the hard work that you've been doing. The bill that I'm carrying here does have bipartisan support, and I want to thank everybody for that as well. And first to the bill itself. Prior authorization is used by insurers, health plans, and pharmacy benefit managers to ensure patients use the medications that are on the health plan's preferred drug list. The theory is that these drugs are the most cost-effective for the patient, but that's not always the case. If a physician writes a prescription that are not on the preferred list, the insurer will not cover that drug unless the prescriber goes to the insurer and gets that prior authorization for that drug. Generally, the drug on the preferred list do not need prior authorization. The challenges we have is that the insurer or the PBMs change the drugs on the preferred list regularly without notice to the patient or the prescriber, and a drug that was on the preferred list in January may not be on the list in March. This is hard for me. You know, my personal experience with this was that, of course, I have multiple sclerosis, and I've been going to the Mayo Clinic for quite a while. And I have world-renowned neurologists. My first doctor, I started going there. This was before I was even elected to office, right? My first doctor, I walked in, and it was a doctor by the name of John Noseworthy, Dr. Noseworthy. Dr. Noseworthy today is the CEO of the Mayo Clinic. I'd like to think he knows what he's doing, right? And Dr. Noseworthy, prior to transitioning into that role, turned my care over to another doctor, Dr. Cantarsi. And Dr. Cantarsi also is a person who is very, very good at what they do. And I think I can share this publicly. Oh, I know I can because she has. Our beloved Mary LaHammer and I share the same doctor. And so, you know, we share notes and whatnot quite often. And so I'm one of the fortunate people that have insurance, right? I'm one of the fortunate people that have a good quality care with the Mayo Clinic. And where this became an issue to me was that one of the things that I suffer with is fatigue. And so I was prescribed a medication to help with that. And when I went to get that medication filled back in February of this year, my pharmacist said, no, I can't get it filled. I said, I have a prescription, why not? And they said, the pharmacy benefits manager has denied. And I said, are they saving money? What's going on? They said, no, get this, Rod. They said that I pay 100% of the costs out of my pocket. And I said, if I pay 100% of the costs and I have a prescription from my doctor. Why on God's green earth can't I get it filled? And they said, that's a question for your insurance company or your pharmacy benefits manager. And that's when I went nuclear, right? Well, when through the reporters with the Star Tribune and Mary LaHammer and Don Davis and others, and I thank them for helping me get the word out. I've been contacted by many people, and they continue to come in with the stories, and I'm not alone. And like I said, this isn't about me. And, when I receive letters from individuals, I have a person here, and I'm getting emotional, that, they said, here's an individual, happens to be living in Representative Melissa Hortman's district, telling me the struggles that they're having with their care, in particular the pharmacy benefits manager. And they say, I'm sure many patients accept the change without fighting it, but a dying patient should not have to battle another battle at this stage in their life. When I was making a scene, one of the pharmacy benefits manager flew in, I don't even know what their title was, and they said, we have a process. In the event we deny your prescription, we have a process. Here, look at this. You can call this number. And I threw it back. I said, why the hell? Why should I have to call you to defend what it is that my doctor has prescribed for me? You do not know who I am. I've never met you. You've never met me. I don't even know if you're a doctor. And you're making these decisions as it pertains to my health. That is wrong. I don't even know how it's legal. Think about it. If you had an injury or something and you went to your local hospital and you walked in and you met with somebody and you didn't even know if they're a doctor, and maybe they're not even a doctor, and they start prescribing your medication or your treatment, that should be malpractice. Why isn't that illegal? And I'm getting off subject here a little bit. I understand that. I'm getting off the bill. But we have a bigger issue. And what I said, when pharmacy benefits managers, when this was put in place, and I said this on the House floor, I thought that they had a good cause, right? Trying to lower costs. But I believe they have completely lost what their initial goal was. And now it's all about profits. And if you read through here, there's individuals that were fighting to be on a generic drug, fighting to be on a generic because it was lower cost for them and they named their insurance provider, but they were denied because the pharmacy benefits manager wanted them on the preferred list to have the name brand drug. This would have lowered dollars for them and their insurance provider, but they were denied. And then if you start reading the various articles and you start to understand why, follow the money. We need complete transparency in this system. Now, thank you, Mr. Chairman, for allowing me to go off in another direction here a little bit. I appreciate that, greatly appreciate that, and I'm going to bring it back in a little bit. But I'm tired and I'm crabby, and I want to make some changes. With that, Mr. Chairman, I'll try to bring us back on the topic, and I'll turn it over to my testifiers, or any testifiers for or against. Bring your A games, people. I'm loaded for bear.
All right, thank you, Representative Hamilton. I understand Dr. Julie Anderson from MMA is up, Sue Aberholden on deck, then Phil Raines. Welcome to the committee. Please introduce yourself for the record and proceed.
Good morning. Mr. Chair, members of the committee. My name is Julie Anderson, and I'm a family physician practicing in St. Cloud. I'm here today on behalf of the Minnesota Medical Association and the Minnesota Academy of Family Physicians, which represents over 3,100 family physicians in Minnesota. Thank you for the opportunity to testify in strong support of this bill. As an outstate family doctor, I treat patients from birth to 99. Sometimes 104, and inevitably they require a prescription. Unfortunately, many prescriptions get initially denied, and our office must go through the arduous process of a prior authorization request. Prior authorization hampers my ability to provide my patients with what I believe to be the best treatment, and is burdensome to my clinic and to my patients. Often it results in my patients being unable to get their medications at the time that they need them. Many folks assume that prior authorizations are only required of high-cost drugs, but most are on generic, well-established drugs and often the lowest cost drug available. And in case you're wondering, Minnesota physicians are very sensitive to cost. We attempt to prescribe generics as often as possible. My clinic is at about 92% in terms of generics. And the only reason why we're not at 100% is because some of those medications don't have a generic alternative. Many patients are on higher cost drugs, like those with chronic conditions like MS and diabetes and mental illness. And they are selected their health plan based upon whether the plan covers that drug that is working for them. These patients are bound by the terms of their contract, and their health plan and nothing in law prevents that health plan from requiring the patient to switch to a different drug, even in the middle of their contract year. When a physician finds the right drug therapy for an individual, switching to a new drug because the insurer requires a change can risk that patient's health. That's precisely one of the things that this bill is trying to correct. Last month, my 29-year-old diabetic patient had his long-acting insulin, Lantus, denied. He's been on this drug for 7 years. My nurse spent 25 minutes online with a prior authorization, and we waited. We waited a week. My nurse then sent a high priority request. We're supposed to hear back within 24 to 48 hours. 3 days later, we still didn't hear back, and we learned that my patient ended up in the ER requiring IV insulin since he'd run out of his insulin and his sugars were dangerously high. This was a completely avoidable trip that could have cost him his life. There's obviously a role for prior authorization, and nothing in this bill precludes its use, nor does it prohibit health plans from offering patient incentives to switch to other drugs. Our point is that an arbitrary change to a patient's drug therapy when it's working is unwise and potentially dangerous. House File 747 requires health plans to inform patients and prescribers prior to any change in their preferred drug lists. If I know what drugs are preferred ahead of time, I will prescribe that drug if I feel it's effective for my patient. I have no problem with that, but I don't get notified currently when the drug lists change and until I've already prescribed them, and then I have to do it on the back end. This change would significantly reduce the administrative burden in my office if there were greater transparency from the insurers and PBMs. All too much of my clinic's time is spent processing prior authorization requests and appeals. Opponents of this bill will tell you that it will make healthcare more expensive. And I would say that prior authorization as it currently operates is already expensive. We have a full-time nurse that spends most of her day processing these requests for 3 physicians in my office, up to 6 drugs a day. She spent 90 minutes yesterday getting the generic antidepressant citalopram approved, only to find out at the end of the process that it was because I wrote for number 30, which is typical, a number 30 tablets, to see if it worked, and then the plan would only cover it if it was written for 34. It just doesn't make any sense. So we should, at our clinic, we should be spending time taking care of our patients and not chasing after health plans for approval. So thank you, Mr. Chair, and members of the committee for hearing this important bill to provide protection to patients and for the opportunity to offer my support for an important bill that puts patients first.
Thank you, Dr. Anderson. We appreciate your testimony today. Next up, we have Sue Abderholden. Welcome to the committee.
Good morning, Mr. Chairman, members. Sue Abderholden from NAMI, Minnesota. On the National Institute of Mental Health website, they post information about all the different medications used to treat mental illnesses such as depression, anxiety, bipolar disorder, and schizophrenia. They talk about the efficacy studies that show there may not be many differences between the various medications, particularly for depression. But then they go on to say, for reasons not yet well understood, some people respond better to some antidepressant medications than to others. And they say every patient responds differently, so it may take several trials of different antipsychotic medications to find the one that works best. As an advocate and as a family member to people who live with mental illnesses, I can tell you that it takes time to find the right medication, the right combination of medications, and the right dosages when treating mental illnesses. And once the right ones are found that stabilize the individual so they can get their life back, you don't want to make any changes. I would lie down in front of a moving train to prevent my family members from changing their meds that work. You really want to hold on to what works. It's devastating then when you find out that your health insurance has changed its formulary and the medication that works is no longer on it. It's bad enough when that happens before the plan year starts, but then to have to look for a plan that has your medication on its formulary, and it's devastating when that happens during the year. People with mental illnesses are expected to simply change their medication if the one they are taking is no longer on the formulary. Now, people will talk about prior authorizations, but I can tell you I have numerous emails from mental health providers in the community talking about the numerous requests, how long it takes. They had someone who was out there without their medications for over 8 days while waiting. We had a situation in January where the health plan, it was a PMAP, was going to reduce the number of injectable antipsychotics available. People with mental illnesses, serious mental illnesses, who were stable, were going to be forced to switch to just the one injectable listed. But you have to know with an injectable, it's not switching. First, you have to prove you can tolerate and be helped by an oral antipsychotic, which can take 4 to 6 weeks. In the literature, it's not recommended to switch an effective antipsychotic for an antipsychotic that has not been tried before, because stopping an antipsychotic abruptly can lead to withdrawal syndrome that might include emergent dyskinesia, acute agitation, and even hospitalization. And again, technically for antipsychotics, there's required coverage under 62Q, but again, obtaining approval for PA is extremely difficult. One study found that when people were forced to switch to a different psychiatric medication, 35% had an emergency visit, and a little over 15% were hospitalized. Medication tolerance and continuation are key to successfully treating mental illnesses. Why would we force people with mental illnesses to change medications that are working? And who are these people? A woman who had to switch antidepressants twice in 1 year, and it destabilized her. She had to quit working until she could get better. A man who had trouble getting the right medications that when the doctor ordered a new one to help with the symptoms, they learned it wasn't on the list and the PA was denied. He didn't know how he would get better. A young woman had to switch her antidepressant because the formulary changed. She ended up not being able to tolerate the side effects of the new medication. She tried another one, plunged into deep depression, and she missed an entire semester of college due to the change in the formulary. A man with bipolar disorder who had to change his meds and ended up in jail after a manic episode. Requiring plans to, at the very least, and I want to just stress that, from our viewpoint, at the very least, to keep the same formulary during the year is the minimal thing that you can do. Changes in formularies threatens people's recovery, and it leads to poor outcomes. Thank you for the opportunity to testify in favor of this bill.
Thank you. We're going to hold questions till the end. Representative Considine. Phil Raines is next.
Good morning, committee members. My name is Phil Raines. I'm with Minnesota Independent Physicians Association, and I want to speak in favor of the bill and want to keep this short. I know you've heard a lot of things about the switching of medications, et cetera. I just want to provide, I think, 2 examples that really highlight the PA problem right now. One was with a meeting with Representative Baker a couple of years back, at which point a physician brought forward a PA that they'd had that prescribed a basic pain medication, just something like Tylenol 3. and had that PA'd, which was ridiculous on its face. And then the suggestion was, why don't you try oxycodone? Put them on an opioid instead. And you just kind of looked at that and went, wow, this is what the PA system is suggesting us to do along the way. And then on the back end, just to follow on that, the most important example I have is a local St. Paul pain and addiction doctor who, when I told him this bill was coming up, called me up and said, please tell people about this. He tries to manage people that are on opioids right now. And he had 2 people come in the last month that he tried to prescribe Suboxone or its generic equivalent. It's all about the same. It's basically a substitute for opioids, helps people move off that and control their addiction. They were PA'd out. By the time that they were able to go back and try to straighten that PA, both of them had overdosed and were dead. And I guess that saved some money along the way. That's a terrible thing to say. But this is real people's lives that are getting messed up by these. And we really need to have something to get a hold of this situation.
Thank you, Mr. Raines. Next up, we have Andy Beam, Vice President, Office of Clinical Evaluation, Policy, Express Scripts. Welcome to the committee. Please introduce yourself for the record and proceed.
Great. Thank you, Mr. Chairman. Thank you for the opportunity to speak today. My name is Andy Beam. I'm the Vice President of the Office of Clinical Evaluation and Policy at Express Scripts. I'm a pharmacist, and I graduated from the University of Minnesota College of Pharmacy. I'm an active member of the Minnesota Board of Pharmacy. Today, I will be testifying on behalf of Express Scripts in opposition to this bill. Express Scripts is a pharmacy benefits manager, or PBM. PBMs are hired by health plans, employers, third-party administrators, and government plans to manage the pharmacy benefit. Express Scripts currently manages the pharmacy benefit for approximately 85 million Americans and is involved in processing and/or dispensing 1.5 billion claims. So we have a lot of experience in this. Express Scripts has a large administrative site in Minnesota, in Bloomington, and the site has approximately 1,500 employees and includes physicians, pharmacists, attorneys, accountants, and a wide range of other healthcare professionals. As mentioned, I'm the Vice President of the Office of Clinical Evaluation and Policy. My team consists of physicians and pharmacists who are involved in tracking patent pipeline issues, reviewing new and existing medicines, creating national formularies, developing prior authorization and step therapy policies, and creating other clinical programs. When Express Scripts develops a formulary, a prior authorization, or step therapy policy, we work directly with independent, actively practicing pharmacists and physicians who make up our national P&T committee. So anytime a decision is made, anytime a medicine is reviewed for formulary status, anytime a policy is developed, they're independent, actively practicing experts who weigh in and need to determine whether or not the decisions are reasonable and appropriate. And only after a decision is deemed to be clinically reasonable and supportable are there ever any business considerations made afterwards. Therefore, really all of our decisions put clinical first before any financial considerations. We think that's incredibly important. The main way we keep drug prices in check are through our national formularies, lists of preferred medicines, and through many of our prior authorization and step therapy programs. In brief, a prior authorization program approves the use of a medicine when there is published evidence to support its use, when there is support within primary literature, guidelines, and/or experts who treat and manage that particular condition. We deny medicines are not allowed or not approvable when a medicine has no data to support its use within the primary literature. So everything that we come up with is an evidence-based decision, and it's based on published literature and guidelines and input from experts. In brief, a step therapy program promotes the use of lower-cost, clinically equal products, typically generics, before more expensive brand name products. So just a little background on both of those programs. Looking at the 2016 Express Scripts drug trend report, clients who had unmanaged pharmacy benefits, so who really had open formularies, who didn't use trend management programs, saw trend increases in 2016 that totaled nearly 10%. Clients who used formulary management and who used the utilization management tools that I just highlighted saw an average trend increase of only 2.6%. So these tools are very effective, they work, and they allow plan sponsors to continue to provide an affordable benefit for their members and to allow payers and who are employers within the local environment to continue to provide a reasonable benefit. Over the past decade, we've seen a dramatic rise in the cost of brand name medicines. I think as mentioned by some of the other presenters, the generic fill rate these days is nearly 90%. But for that 10% of brand name medicines that are used, the costs have skyrocketed. If you went back to 2008 in January and you had $100, if you took a commonly used basket of brand name medicines, those products have increased 290% in the last 10 years. At the same time, if you looked at a market basket of commonly used household goods, the price had only increased 14%. And even more astounding, if you looked at the use of generic medicines, they've declined in costs by 74%. So there's this huge divergence where brand name products are escalating in price, generics are much more affordable and lower cost. It's not uncommon these days for these brand name medicines to be approved and to initially launch at a price of $100,000 per year. The prices are astounding. And so plan sponsors are, very appropriately and reasonably targeting those medicines and saying, we need physicians to answer 5, 6, 7 questions to make sure the use of this medicine is reasonable and appropriate and consistent with the literature. One example of a brand name product that has had some pretty astounding price increases is a product called Evzio. It's a brand named naloxone auto-injector, the Save Shot, that has been talked about in the press for patients who overdosed on an opiate. This particular product, if you look at naloxone products, there are several products that are available in the range of $15 to $20. This Evzio product was approved in November 18th of 2015 at a list price of $690, which is already a pretty astonishingly high price. On November 23rd, 5 days after it was approved, they increased the price 31% to $900 per shot. And on February 1st, roughly 3 months after it was approved, and 1 month after formularies were typically set, they increased the price 400% to $4,500. Overall, that was a 552% price increase in a little over 2 months. And those are the types of price increases we're constantly dealing with, and manufacturers not only have significant price increases, but very frequent price increases. To protect against these frequent and significant price increases, plan sponsors need the flexibility to administer their benefit in a manner that takes advantage of their formulary tools, generic opportunities, and clearly prior authorization tools that make sure that medicines are used appropriately. We believe that this bill creates some unnecessary regulation and barriers around those programs and tools. And this bill would certainly be a boon for pharmaceutical manufacturers and would essentially create a blank check environment where employers and inevitably patients via higher premiums and reduced benefits would pay for them. Thank you very much for the opportunity to speak today.
Thank you, Mr. Boehm. Next up, we have Abigail Stoddard from Prime Therapeutics. Welcome to the committee. Please introduce yourself for the record and proceed.
Thank you. Good morning, Mr. Chair, members of the committee. My name is Abigail Stoddard. I'm also a pharmacist, and I'm with Prime Therapeutics. I want to take my time in testimony today to tell you a little bit more about who PBMs are and how we fit in the healthcare industry. As Andy mentioned, PBMs have the very difficult job of balancing access and affordability because the most robust prescription benefit that an employer can provide is only as good as the premium that the member can afford. And I'm sure all of you have already heard from your constituents that premiums are hard to afford already. PBMs are vendors that are hired by clients such as health plans, major employers, labor unions, and we are hired specifically to manage the prescription drug aspect of their healthcare benefit. So for Prime, for example, we're the vendor that makes sure that when a Blue Cross member goes to the pharmacy counter, that prescription drug claim is paid. But again, I want to be very clear that when we pay those claims, we don't pay those claims with Prime Therapeutics money. We don't really even pay those claims with Blue Cross money. We pay those claims with money collected from all of the employers in your district who are trying to do the right thing and offer an affordable health care benefit. And we pay those claims with the money that's withheld from all of the paychecks in your district from members who have commercial health insurance. Our job, and the reason why we are hired and the reason why this industry exists, is to try to make sure that those prescription drug dollars are spent as efficiently as possible so that everybody who needs prescription drugs has access to them. And that job is, of course, increasingly difficult. But when we say a given policy costs money, I want to be very clear that it does not cost Prime Therapeutics money. It doesn't really even cost our health plans money. It costs all of the constituents in your district and all the taxpayers in your district's money. Similarly, when we say something saves money, that's not money that we keep. That's money that stays with the employer group. For the state plan, for example, I think that's a perfect example. If something saves the state plan money, that's money that doesn't have to come out of state employee paychecks, and that's money that stays in the general fund to be used for any other priority that you may have. When it comes to the premium dollar, we are now at a precipice. 22 cents of every premium dollar is now spent on prescription drugs. 22 cents, that's more than we pay for physicians, that's more than we pay for hospitals. And as Andy said, a large part of that is due to price increases, which is not addressed at all in the policies in these bills. For the last 2 years, 69% of all spending growth in Minnesota is tied simply to price increases. No new innovation, no new products, just price increases, and prescription drugs are no different. We have been discussing this policy for the past several years in the Senate, and you may have heard that the PBMs are stubborn and uncompromising on this issue. And that's simply because any way you slice it, this policy restricts our ability to use formulary drug lists and to use prior authorization tools to control the cost of the health care benefit, plain and simple. Anytime that happens, that's why we show up to discuss these policies. I'm a Minnesotan. I live in Minnesota, but I work on this policy in many other states. I can tell you this session alone, it's been seen in several states that are vastly different ideologically. States like from New Mexico all the way to a very different state of Florida have considered this policy. And everywhere it's been considered and researched, it has been shown to increase the cost of the healthcare benefit with no added access, no added outcomes. And so everywhere it has been considered this session, it has ultimately failed for that reason. So with that, Mr. Chair, I will close. I'll be available for questions.
Thank you, Ms. Stoddard. Next up, we are going to have Bentley Graves. Welcome to the committee, Mr. Graves. Please introduce yourself and proceed.
Thank you, Mr. Chair. My name is Bentley Graves. I'm the Director of Healthcare and Transportation Policy at the Minnesota Chamber of Commerce. Appreciate the opportunity to testify here this morning. You've heard very compelling testimony from the folks who support this bill, very compelling stories from Representative Hamilton about their view of some of the shortfalls of the prior authorization process, the use of formularies. But you also heard, I think, compelling testimony both from Mr. Boehm and from Ms. Stoddard about why these tools are in place. And as an organization representing employers who pay the lion's share for health insurance costs for most Minnesotans, these are important tools. This legislation was looked at on the floor of the House recently. I think many of you recall that the Chamber circulated a letter when that legislation was being debated. And rather than take up a lot of time kind of rehashing our concerns, I just wanted to read just a couple excerpts from that letter, and then certainly happy to answer the questions. But as you heard from the previous two testifiers, prescription drug costs are the largest driver of increased healthcare costs for employers and their employees. Health insurers and self-employed insurers have relied upon tools like formularies and prior authorization to help control rising drug costs and to help ensure that the health and safety of their customers and employees. This bill would restrict insurers and employers' use of these important tools, and healthcare costs in Minnesota will rise as a result. At a time when premiums in the individual market have increased nearly 70% this year, and employers in the small group market once again were forced to contend with double-digit increases in their premiums, the legislature should not pursue proposals that will only add to the cost of health insurance. But again, noting the testimony received here this morning, we do understand that there are concerns about both of these tools and about prior authorization and formularies that patients have. And we're certainly committed to continue conversations about finding a way to address those concerns. But as the fiscal note from the Senate noted, this legislation does come with a cost, and we aren't able to support legislation that, again, would add to the cost burden for employers and their employees at this time. Thank you very much again for the opportunity to testify.
Thank you, Mr. Graves. We do appreciate you being here today. Next up, we have Dr. Charlie Fazio. Welcome to the committee. Please introduce yourself for the record and proceed.
Good morning, Chairman Dean, Representative Hamilton, committee members. Thank you for the opportunity to testify on House File 747. For the record, my name is Dr. Charlie Fazio. I'm the Medical Director and Senior Vice President at Health Partners, but I'm here today representing the Council of Health Plans. We oppose House File 747 and the restrictions it imposes on how health plans manage coverage for prescription drugs. As you've already heard, the cost of prescription drugs now accounts for more than 20 cents of every dollar spent on health care, more than we spend on hospitalizations. It's also been curious to me this morning to hear that most of the testimony you've heard is actually about prior authorization, and I feel compelled to mention two facts relative to Mr. Raines' testimony. None of the local plans in any process that I can imagine would recommend to a practitioner that they prescribe an opioid. I would also let you know that none of the local plans has a prior authorization process in place for Suboxone or any other medication-assisted therapy that relates to withdrawal from opiates. Much of the testimony you've heard is about prior authorization. This bill is about formulary substitutions. House File 747 would prohibit health plans from making changes to formulary mid-year in an enrollee's contracts. You've heard this. New drugs come out often, sometimes replacing other drugs. Sometimes during the year, the drug company raises prices significantly, pushing the costs that plans and consumers have to pay. As a result, it's essential that health plans be able to evaluate the best course of action. If we make a change in the formulary at Health Partners, we give members a 60-day notice and ensure that they are able to be transferred to a drug that is absolutely equivalent. All decisions on what is considered equivalent are made by a panel of medical experts comprised of community doctors. And if the prescribing physician believes that it is medically necessary for the patient to stay on the drug they are on, then we make that allowance. And there's 60 days for them to work out that process. A prime example of this kind of a substitution was in the last couple of years when we replaced one form of insulin with a different brand of the exact same acting insulin, saving $7 million in the course of a year. We also believe that if more doctors adopted prior authorization electronically, or EPA, as Minnesota has mandated since January 1st of 2016, that it would streamline their prescribing processes, as noted in a recent Star Tribune article. We would also like to note that not all employer group contracts renew in January. So having to grandfather a member's drug would essentially mean 12 different versions of our formulary for each line of business, creating a lot of administrative hassle. This bill also applies inconsistently across commercial payers and within public programs. I won't repeat the statistics that Ms. Stoddard quoted about the financial effects of this bill. The cost of health insurance reflects the cost of health care. We cannot ignore the dramatic increases we're seeing in drug prices. You've spent much of the last few months trying to restore stability to the individual market. Removing tools that help payers control the rising cost of drugs is counter to all of those efforts. This bill is counter to all of those efforts. For the above reasons, the Council of Health Plans is opposed to this bill. We agree completely with Representative Hamilton that the issue is much bigger than what is contained in this bill. So at the very same time as we oppose this legislation, we would love to work with the legislature to find meaningful ways to address the ongoing challenge of the price of pharmaceuticals for all Minnesotans. Thank you for the opportunity to testify.
Thank you for your testimony, Dr. Fazio. We do appreciate that. And next, is that Tom Kelleher. Welcome to the committee. Please introduce yourself for the record and proceed.
Good morning, Mr. Chairman. I'm in a strange position this morning. My name is Tom Kelleher. I own Kelleher Government Affairs Consulting. But I'm here on behalf of my stepdaughter. And like Representative Hamilton, she's had MS her whole life. I wish I'd put on another jacket this morning because I don't have the document that I saw yesterday from CVS Specialty Pharmacy. It basically says she can have Caploxone from February of this year till February of 2019. Says it very clearly in the memo. I'd be happy to provide it for anybody in the committee. Except for they won't provide the drug, even though she's got a prior authorization document that says so for 3 years. It's an expensive drug, and I'm not here to talk about the pricing of drugs. I've represented drug companies in the past. I get it. I understand the price of drugs and the pricing. But she's got a document that says she can have, it's prior authorized. And what happened day before yesterday is the company Teva, who makes the drug, mailed her a free sample because they got tired of listening to us bark at them about why the CVS Pharmacy Group is not abiding by their own prior authorization document. Now, I understand that maybe Representative Hamilton's bill doesn't fix all these problems, but these are problems. And I'll tell you one personal example from me 3 days ago. It's a little silly. I was shaving in the morning, just doing this, dumped a bunch of my pills into the sink. Well, they melt, and you can't get them back. So I called my pharmacy. I have a replacement policy for stolen or spilt drugs in my plan. The pharmacy goes, well, and even though I had a refill on the bottle, they go, well, you got to get your doctor to refill the prescription. It's fine. I call my doctor. I have his cell phone. He's on the phone with me. He refills it. The pharmacy won't refill it because they got to verify his refill. They had to have him call back after he'd already called and sent in the refill to verify that he authorized the refill. I thought that was, we talk about bureaucracy and unneeded steps in order to fulfill drug prescriptions. I mean, this is one of them. So I'm talking to the pharmacist, and she starts telling me how it's state and federal law. It's a controlled substance. I go, I work at the Capitol. It's not state law. And she goes, well, it's policy at CVS. And I go, well, you can avoid policy. You can void that. She goes, well, no, we have very strict guidelines. We can't do that. So I guess in conclusion, what I'm saying is that this is a big problem. Representative Hamilton and I have talked. As all of us get older, we have prescription drugs that we have to take to keep us to become more older. My stepdaughter has had MS since she was like 5. And she's been getting the runaround from specialty pharmacy clinics, health plans, who I won't mention by name today, since she was a kid. And if it takes somebody like me to really get involved and call the drug company, the specialty pharmacy clinic, the pharmacy, blah, 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 the health plan, I've done it. And they give me the runaround. And I'm pretty abrasive, as you can imagine. I know most of you. I'm pretty good at on the phone and one-on-one on getting things done. And I have never found such an obstinate group of people that represent pharmacies, drug companies, health plans, you name it. I mean, it is very, very difficult. Thank you very much, Mr. Chairman.
Thank you. And member questions? Representative Considine.
Thank you, Mr. Chair. Mr. Kelleher, you mentioned that your daughter started this at 5. How old is she now?
31, Mr. Chair.
So 26 years this has been going on.
From my understanding, she's been my stepdaughter for about 12 years.
Okay. My next question would be to Ms. Aberholton. I have a couple, by the way.
All right.
Mr. Chairman, I'll be available.
Thanks.
Thank you very much.
Actually, it's the same question. How long have you been dealing with this problem?
Ms. Abderholden.
Mr. Chairman, Representative, well, I've been with NAMI 15 and a half years. My family members, it ranges from 20 down to 10,
A long time.
a very long time.
Okay. Thank you. That was my only question for you. I'd like to talk to the woman in the gray suit.
Ms. Stoddard, will you please come back to the testifying table?
I don't,
Welcome back to the committee, Ms. Stoddard. Representative Considine.
Thank you. In your testimony, first of all, how big is Prime Therapeutics?
Ms. Stoddard.
Mr. Chair, Representative, we have close to about 4,000 employees, 90% of whom are based in Minnesota.
Okay, and a couple times, and you mentioned that, well, we don't profit from this, we don't profit from that. Where do you get your money?
Ms. Stoddard.
Mr. Chair, Representative, thank you for that question. The way Prime operates is we charge an administrative fee for the claims that we pay. So the cost of the claim is the cost of the claim. We charge an administrative fee to the health plan, labor union, whoever, for processing that claim. So regardless of the cost of that claim, we pay it with their money. We charge them a fee to process it.
So then you actually do get money that goes into health premiums, despite what you said earlier, that the source of your income is coming out of people's pockets that are paying premiums.
Ms. Stoddard.
Mr. Chair, Representative, we do charge an administrative fee. That is, of course.
You said that already.
Correct.
The money that comes from out of the people's pockets that are paying for their premiums.
Correct, but nonetheless, we are hired because we can bring down the cost of the claims that they are paying, because they have to process those claims regardless of whether or not Prime does it or they take the cost and do it themselves. We are hired because we bring down the costs of the claims.
Nobody asked you that.
Representative Considine, if you could go through the chair.
Thank you.
Representative
Sorry.
Grunhagen.
I hadn't finished, though, Mr. Chair.
Representative Considine, I think we need to move on to Representative Grunhagen. And I think you need to be more respectful of the committee process and also the testifiers. We can put you back on the list. Representative Grunhagen.
Oh, thank you, Mr. Chair. I'd like to, Ms. Stoddard, if you'd stay there, and then Andy Beam, if he'd
Beam.
come forward. Just one thing, I sell Medicare Supplements Part D drug plan while he's coming. And I had a customer come into my office who's been a long-time customer, and he told me, this a couple years ago, he says, "Glenn, I'm going to die." I said, "Well, we're all going to die." I said, "What's wrong?" He said, "I've got a rare form of cancer, and there's only one prescription that helps me. I could take one pill a day." He says, and I said, "Well, what's the problem?" He said, "It costs $9,000 a month." A month. And he's still alive today. It was covered by his Part D drug plan, but, it just scares the bejeebers out of people. I mean, that $9,000 a month. So my question is, who provide, Mr. Beam, and thanks for what you do. I know it's not easy, what you're dealing with between government and the private sector and the medical community. But, who provides the evidence to your companies that guides you in making these decisions to make these formulary changes that evidently in some cases are causing adverse health effects? Is it a government agency at the federal level? Is it within your own company? Is it multiple sources that provide you this guidance to make these changes that cause disruption in the market? Who provides you that evidence?
Mr. Boehm or Ms.
Mr. Chair, I'm going
Stoddard?
to give that to you, Mr. Bain.
Yeah, sure. I would say at Express Scripts and at most PBMs, it's a twofold process. The first step is, as I mentioned, we work with outside independent, actively practicing physicians to review all the published literature, to look at guidelines, to look at package labels, to be very astute on the clinical implications and the placement in therapy of each and every medicine. Only when a group of actively practicing physicians, experts in their field, state that medicines are considered therapeutically similar to one another and that it would be reasonable to select one of two or one of three agents, will we then move on to an economic consideration. And in that instance, that's sort of step two after the clinicals are ironed out and everybody is doing the right thing clinically. Then we'll look at the cost of the medicines and say, if there are three medicines and one product is disproportionately less expensive than the other, that may be considered a preferred product on the formulary. The other two may or may not be on the formulary, and that's how the formulary decisions are made. But I'll point out it's always a clinical first decision, and then it's only economics after those considerations are made. And we always work with actively practicing specialists and experts. And just one other final point, you did mention, we agree with you wholeheartedly. The cost of some of these medicines is exorbitant. If you look at the drug trend report from 2016, the average out-of-pocket cost for a patient these days is $11.34 per claim. And a lot of that is we try to keep those costs as reasonable and affordable as possible by these formulary changes and by working with those outside experts. Thank you.
Mr. Chair, one follow-up question. Yep, real quick.
Representative Gruenhagen.
I could have about 50, so I'm keeping it down to 2. Okay. The other area is obviously what I see as one of the main drivers is the price increases that are going on and the prices coming out on new drugs. So you've got a lot of experience in this area. I've got my own opinions about what's driving these costs up. But why do you think these costs are being driven up like this? And it seems since we passed Obamacare, it's gotten worse, not better. There's no tort reform in Obamacare. So I'd just like to hear, why are these prices? Is it lack of competition? Is it just they can raise prices because they can? Is it liability? Turn the TV on every time you see a bunch of lawyers advertising to sue pharmaceutical companies. What is driving these costs up? Maybe the three primary things.
Ms. Stoddard.
Mr. Chair, Representative, thank you for that question, and I think you hit the nail on the head. The prices increase because they can, plain and simple. I think the example you gave earlier of the opioid overdose rescue shot, the shot that will literally bring you back to life when you are overdosing, that company has a patent from the federal government. They have a monopoly on that product, and they know that we will pay and that employers will pay for that product, whether it's $600, $1,500, or $4,500 a shot, which it is now. They raise the price because they can. In your oncology example, in the Medicare program, those is what's called a protected class drug, meaning that all of those drugs are always covered. If you are a pharmaceutical manufacturer in that environment, what would you do? Regardless of the price that you charge, we're going to pay for it. So that's why we see this access problem of, it doesn't matter if the person has a 5% copay, a 10% copay, that drug's $100,000 a year. So it doesn't matter what benefit you do have or you don't have. You can't afford it, and they'll keep increasing the prices simply because they can.
Thank you, Ms. Stoddard. We're going to move on. Representative Liebling, Zerwas, Lunan, Schultz, Pinto, Murphy, and that means that we will be coming back for the second bill after session. I do want to conclude this so testifiers don't have to come back later on this bill, but we will move through member questions. Representative Liebling, did you have a question, or did I automatically put you on the list after Representative Grunhagen?
Mr. Chair, you just knew I'd want to be there. Absolutely.
Representative Liebling.
Well, thank you, Mr. Chair, and I do appreciate that we are having this hearing, and that is a good first step. And of course, I really appreciate Representative Hamilton and the heart and soul that you put into this, and I really thank you, because this really is about a lot of people. It's about really every patient who needs medication. I really appreciate that. So I want to say a couple of things. First of all, and the testifiers, it's not really a question, but the testifiers can certainly comment on it if they want. But I've been kind of looking up some information on Express Scripts and Prime Therapeutics, and of course they are for-profit companies. I believe that Express Scripts is probably 22 on the list of Fortune 500 companies. I haven't been able to find complete information just sitting here looking on my smartphone, but these are companies that are making billions of dollars a year. These are huge companies. Now, I get that there is a fight going on between the big PBMs, and just for people who may be watching, pharmacy benefit managers. I think most people probably have never really heard of them and don't know what they are. Yeah, but if they're watching this hearing, maybe they've learned a little bit more. And I know there's a struggle between the pharmacy benefit managers and the big pharmaceutical companies. We've just been hearing a little bit about that. But these are huge for-profit companies who are making a profit from this. One way or another, this is costing patients money. And the thing is that when things happen, like a patient doesn't get the right medication and ends up in the emergency room, that cost is borne by other people. Of course, it's borne by the patient in terms of their health, but it's also borne by whoever is paying those costs, whether it's the public, through our public programs, or another insurance company who's paying for that patient's health care. So, this is just an enormous problem. And, despite all the sort of wringing of hands about how this bill would increase costs, this bill is such a modest attempt to make things a little bit better for patients. This bill is not getting rid of the prior authorization process. It is not putting the pharmacy benefit managers out of business. None of that. It's doing some very simple things. It's saying that when you when you buy your insurance, that the formulary, the stuff you think you're buying, is supposed to still be there for the term of the period of your insurance. Boy, what a no-brainer that is, right? What a no-brainer that should be. And part of the bill says that the health plan is supposed to just make you aware by electronic means what its formulary is, what drugs you would have available to you covered under your plan when you buy it. That seems like another really big no-brainer. And the bill allows the formulary to be changed under certain conditions. So this is not a bill that's putting these PBMs out of business. This is not a bill that is going to, the parade of horribles is just astonishing. Just astonishing. But I think the overall message here is how wacko our entire healthcare system is, and how much we need to straighten it out, because I think Representative Hamilton said it very, very well. Follow the money. This is about profits. Thank you, Mr. Chair.
Thank you, Representative Liebling. Representative Zerwas.
Thank you, Mr. Chair. So I'm in an interesting spot, because the last thing I want to do is put forward policies and bills that will adversely impact the cost of care, and increase the cost of care. But I think we have to come to the realization that the current system and how we treat patients isn't right. It just isn't right. If I sign up for a health plan, the very first thing I do is I check to make sure Minneapolis Children's and the Children's Heart Clinic is among one of the providers that's covered. I'm 36 years old. For 36 years, my experience with healthcare has been, for my family and now myself, you got to make sure you find health insurance that covers the heart clinic. It covers Children's Hospital. Of the 10 open heart surgeries I've had, absolutely 0 of them were elective. I didn't get to pick the time. I didn't get to pick the schedule. I didn't get to make sure it was convenient. I didn't plan for it. When my mom got breast cancer, she didn't schedule it in to her date book. She didn't plan out 6 months in advance when they picked their health insurance for the year. And so the big part of this that I don't get is if you know you are sick and you know you need a drug and you know what drug that is, and you have to switch insurance companies because it's open enrollment or you're getting a new policy, and you take the opportunity to do the due diligence, to actually look at the formulary, to do everything you could possibly do. Everything as a patient you could possibly do to ensure that the drug you need is covered on that formula. You do everything right. 1 month later, the pharmacy benefits manager in your insurance company can pull the rug out from under you. Don't worry, they'll send you a letter 60 days ahead of time so you can figure out what the hell you're going to do next for 60 days. I think the idea of getting rid of benefits managers or getting rid of any type of prior auth schedule, I think that's not okay, and I think that's going too far. But I think we got to find some compromise, because if a consumer can't do due diligence and sign up for a 12-month plan and get what's on that document from day one, if that's not guaranteed to be available to them on day 12, then why the heck does anything else in that contract matter either? So at some point, we have to be realistic about this. We have to be fair about this. And we have to let patients take control of their health care. And if they are doing everything right, we cannot still punish them. That is wrong. It is immoral. We have to do better.
Representative Lunan.
Thank you, Mr. Chairman, and I too want to thank you for hearing this bill. I'm in the insurance industry, and I'm very frustrated about situations like this. I want to thank Representative Hamilton for this, and I'm going to join with you on these battles. What's going on right now is not working. No look of surprise in anybody's faces. Because the question I have, first of all, for Ms. Stoddard is the charges the fees that your company collects. Is there something in your contract that the savings you cause exceed what your fees are?
Ms. Stoddard.
Mr. Chair, Representative, I'm not sure I entirely understand that question.
If you charge $1 million to a health plan, health group, whatever, is the expectation that the savings they will incur because of your involvement will exceed that $1 million.
Ms. Stoddard.
Mr. Chair, I can't speak specifically to that. What I will tell you, though, is that we are 100% transparent with our clients, and we are in fact owned by our clients, and we do have performance guarantees in our contracts. So if that is a performance guarantee that our clients would want of us, that would be in our contract, but we are owned by our clients, so any savings there that they would want in their contract, they would put in there and we would abide by.
Ms. Stoddard, I think what he's saying is that you're not in business to lose money, and if you didn't bring down cost, you'd go out of business. Is that correct?
Mr. Chair, thank you. Absolutely. I think one of the main things to remember about PBMs is that I know there's a lot in the media about whether or not we bring down costs. I would simply ask you to look to all of the employers in their district and the health plans in your district and ask them if they use a PBM. I think you'll be very hard pressed to find someone who doesn't, because that's exactly what we do, is we bring down costs.
All right, wrap up, Lunan.
It's going to take 3 wraps.
Come on.
First of all, here's what, just to everyone in the room, here's what's going on in insurance. It isn't the onus of the insurance companies to lower cost. What the insurance companies put a priority on, this is my opinion, but it's a relatively informed one, is predictability. And what that does is it mitigates their risk. They are allowed to charge premium. They are allowed to pass things on. So the example right here of the cost of this entity in there is allowed to flow through. We had a situation where earlier Dr. Fazio talked about administrative hassles. They just transfer that. They just transfer it down to the medical provider, who then is allowed potentially to add that onto the billing, which subsequently ends up on the premium. What we're doing right now is not working. I should say that after every statement. What this bill, the biggest problem with this bill is we're talking about, we have a screw we need to get into a board, and we have a hammer. It's all we got to put it in, and we're arguing about who gets to hit the hammer. We actually have to go after the root of the problem, which is the cost of health care. All these administrative things all get passed on. It happens in property casualty. It happens in health insurance. To me, it's obvious, but to do bills that will go after the root of the problem rather than keeping to just trim off different leaves. For instance on that, we need to take a hard look at these pharmaceutical companies who are able to charge whatever they want, are allowed to market to create a demand in the population, not medical providers, not trained medical professionals, but with the consumer, to create a demand for it. We don't allow that with cigarettes, because we know if you advertise cigarettes, you're going to create a higher demand for it. That's something we as legislators need to take a look at as part of this. There also has to be daylight between the medical provider and the insurance company. I've met with the Minnesota Department of Revenue. I contend the relationship is an employee-employer one, not independent contractors one. I got problems with the amount of control insurance carriers have over these medical providers. Medical decisions should be made by medical professionals. And I look forward to working with you going forward, Representative.
Thank you, Representative Lunan, Representative Scholz, Pinto, and Murphy, and that's it. I'd like to try to wrap up in the next 5 minutes.
Thank you, Mr. Chair. So I have a question for Express Scripts. Has there been any instance where a brand name was substituted for a generic? A brand name was indicated and preferred over a generic that was cheaper?
Yeah, I would say
Bain.
it's standard practice that all generics are covered on our formularies and are clearly preferred. There have been recent examples where certain generics have been launched into the marketplace, and they've been launched at very high prices that are very similar to the brand name product. After discounts on the brand is actually less expensive to the employer and to the patient. I should say to the employer for certain. The patient, from a copay perspective, could be an interesting dynamic. But point being, yes, I think there are probably some very extremely rare scenarios where that would occur. That's clearly not the standard.
There have been instances, Mr. Chair, that a brand name was recommended over a physician's prescription for a generic.
I would say that it's a possibility on the commercial side, and the reason that would be a possibility would be because the net cost of the brand name product was literally less expensive than the generic. So bottom line, Express Scripts, working with plan sponsors, are always looking to encourage the use of the lowest net cost product.
Mr. Chair, Representative, if I could add, I think it's very rare in the commercial benefits that we administer, but one of the more common lines of business where that occurs is actually state Medicaid. And if you look at the DHS fee-for-service formulary, you'll see a few instances of that. I think across the board, that's the most common place you'll see it is in your state Medicaid program, and there are instances where they do that because, to Andy's point, the brand manufacturers will offer the state a rock-bottom price that even beats the generic.
Okay, thank you. Mr. Chair, so I think there are some key things that we could accomplish in a bipartisan fashion, and that is to reduce the time for prior authorization. I understand the value of PBMs and how they can save money in our healthcare system, but I don't think it's right that patients are switched in the course of their treatment to another drug that may not be tolerated and may not be as effective. And when you sign a contract, that contract should be enforced without any changes. And that I would encourage the PBMs to, in that contract with pharmaceutical companies and products, is to set a price and not allow them to increase the price during the time of that contract. So patients will not see price increases. So that's what I would like you to work towards on setting those contracts and prices. If we pass the legislation that allows people to stay on the drug during the time of their contract, and pharmaceutical companies know that, they're going to have an incentive to increase the price. If you don't have those set in contract, the price not increasing. So I could definitely see that happening and them game the system. So that would be my concern. And then one last question, Mr. Chair, just a clarification, Representative Hamilton. You stated that you were paying the full price of the drug that your physician prescribed to you, and that you were not allowed to fill it even though you were paying the full price. Is that correct?
Mr. Chairman, Representative, that is correct.
So you were not expected to have any insurance cover part of that, the cost, but you were not allowed to fill a prescription even though you were paying full price.
Mr. Chairman and Representative, yes, and I was asking why, and I wonder if that had to do something with my deductible calculation or not, but that is correct. I paid 100% of the cost of that prescription, and still do, the cost of that prescription.
And they allowed you to fill it?
No,
They did not allow you to fill it.
no, they did not allow me to fill it.
Thank you.
Representative Pinto and then Representative Murphy, and we're going to have to scoot out of here at 3 minutes because I think that's the slowest person's ability to get to the floor. So
I'll speed it
Mr. Chair,
up.
I'll be very quick. Mr. Boehm, I'm struggling with a contradiction in your comments. You emphasized that clinical determinations are paramount, way, way more important. That's the first thing. That's the primary thing.
Absolutely.
And then you provided all the numbers and all the focus on cost. And you had 2.6% increase for managed plans, 10% increase for unmanaged. Maybe that was, I think that was you, Mr. Boehm.
Yes, sir.
All the emphasis on cost. And I won't ask you to provide this information now in the interest of time, but I will say I would find your emphasis on clinical determinations over cost determinations much more persuasive if that's where your focus was. And I would like to see numbers. I'd like to see data that shows, in fact, yes, that there's much better clinical outcomes. That's our focus. That's our focus. That's our focus. When you are, in the words of Ms. Stoddard, you're hired to bring down costs, it's hard for me to believe then that those clinical determinations are paramount, especially when I hear the statements from Representative Hamilton. Representative Hamilton, please keep this up. Patients and Minnesotans are looking to you for leadership on this. Thank you, thank you, thank you for pursuing this. Thank you.
thank you. Sorry to abbreviate that, Representative Pinto, and to complete Representative Murphy, and then we will recess and come back later.
Thank you, Mr. Chair, and also to the two testifiers that are here. And I'll be brief as well and just very direct. I want to understand from your perspective if your decision-making trumps the decision-making of the physician providing care. Is your clinical or your policy-driven decision-making paramount in the work that you do, and more important than the provider writing a prescription, the doctor or nurse practitioner writing a prescription for the patient that they're caring for?
Yeah, I can answer that.
Mr. Beam.
Oh, I'll just say first and foremost, every one of our decisions is clinical first. And my apologies if I got to the numbers and didn't emphasize the clinical, but clearly we're always working with actively practicing physicians to develop evidence-based policies. Now, what I will say is that ensures that a medicine is used in a manner that's consistent with published literature, that it's not used for experimental purposes. So when payers are using their dollars and when patients are spending their dollars, in fact, it's for uses where there is evidence to support that particular use. There are rare instances where a policy says something's approved, or I should say where it's denied, and a physician has a great argument and they would like to describe the patient-specific scenario. They're afforded that opportunity through an appeals process and through an opportunity to express the situation of their individual member. And that's clearly, clinical first, and it's physician to physician in those instances.
And Mr. Chair, and thank you for that. So what I'm hearing is that it is the judgment of the PBM and their review of literature that is trumping the clinical judgment of the provider who's seeing the patient and writing the prescription. And if that provider who is caring, and I'm a registered nurse, you should know that part, the provider who is seeing the patient, making the clinical determination, writing the prescription, doesn't meet with your approval, then they can make an appeal to you and to your panel.
Absolutely. Yep. It's evidence-based, and they have the opportunity to
And
discuss that
Mr.
individual
Chair, I know we
member
only have
if they're
2 minutes,
using
so
it
I'll
in an
just say
off-label
this,
manner.
Mr. Chair.
I
Thank
want to
you.
give Rod one, so.
Yeah, I want my minute. I want my minute in the sun here. If Minnesotans were filling this room right now, they would be, I think, nodding their heads and understanding why this is messed up, why this is not the right policy for the people of Minnesota. And I hear you arguing that the work that you're doing is to drive down costs. I see you adding costs to the system by denying care to people, by switching up the formularies, by making the health care for people who are sick less reliable and more of a hassle. And across the state of Minnesota, as people are thinking about health care right now, they are fed up. And when we think about the complex vendors, profiteers that have wound their way into our healthcare delivery system in between patients and providers, it is a thorny mess. It is a mess, and this is just the tip of the iceberg, Representative Hamilton, from my perspective. And when we allow entities that want to make money to insert themselves between a provider and their patient and their clinical decision-making, I think the patients, Minnesotans, are going to pay the price for that. So I really appreciate your candor here with us today, letting us look under the lid a little bit of how the work that you do is functioning. But I do think we have to question overall, the way that we are allowing entities like PBMs to intervene on behalf of the payers at the expense of Minnesotans.
Representative Hamilton, final thoughts? And
Thank you,
then
Mr.
we're gonna-
Chairman. If I had time, what I'd ask the testifiers here is I would want to know what percent of the savings are captured by the PBMs and how many rebates and discounts that they do receive in addition to the fee that you charge. Follow the money, Mr. Chairman. We need complete transparency in this healthcare system. Going back to Representative Lunan, we should outlaw drug commercials. It's absolutely ridiculous when you sit down for the news and you see 5, 6, 7, 8 commercials on drugs. It's absolutely ridiculous. And to the testifiers also, if you have 14 other states that have introduced legislation similar to this, you may want to reevaluate your business model. It is not working. People are being hurt. Real people are being harmed, and understand the true cost. When they're saying that this will increase costs to patients, the Senate fiscal note claimed that it would increase costs, and it equated out to about 40 cents per rate carrier. All right? Now let's take a look at the other side of the equation, the amount of profits that they're making on the other end. Let's take a look at the amount of people that are being harmed because of the decisions that they're making, right? They say clinical first. I disagree. I think it is profit-driven. We should follow the money, and we need complete transparency. Thank you, Mr. Chairman, for your time.
Amen. Thank you, Representative Hamilton. We are going to recess. Members, watch your email. We will be coming back to do the Department of Health bill. So watch your email, and we will be back in this room. Leave your packets on the table. Thank you.